Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the care of patients with urologic cancers with Dr. Michael Karellas. Dr. Karellas is an assistant professor of urology at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
Michael, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Great. So I'm a urologic oncologist, meaning I focus my area of care on urologic cancers, which specifically are kidney cancer, bladder cancer, prostate cancer, and testicular cancer. So I handle surgical management of these conditions as well as coordinate multidisciplinary approaches for some of those cancers that need help with medical oncology or other treatment options as well.
Fantastic. And I think many of our audience might know what Movember is, but can you kind of educate those who might not have heard the term?
Of course. So Movember is a recent initiative to focus on men's urologic cancers for the most part, but also with a focus on men's mental health. So initially it started with to raise awareness for prostate cancer, and people would grow various forms of facial hair, whatever they could muster or choose to do. So it was a very individualized way of trying to support men's health, which has also evolved into somewhat of a testicular cancer awareness program and also an aspect of mental health. These cancers have a significant aspect of impact on not only a man's mental health, but also the impact on the rest of their family. And so this is an initiative to raise awareness for those cancers.
Fantastic. So when we think about, men's cancers in general, that largely fall into the bucket that you mentioned that you're specializing in, the urologic cancers, can you kind of paint a picture for us of what the spectrum of disease looks like? How often do these occur? What the prognosis is? That kind of thing?
Sure. So one of the areas that attracted me to my specialty is that most of the cancers we take care of are very curable and treatable, especially if we catch them at early stages. And so the most predominant cancer we probably treat is prostate cancer. It's the second leading cause of cancer deaths among men, although we're very good at diagnosing and treating it, and the overall death rate is approximately 3%. But it's very, very prevalent, very common, and there has been some controversy recently about how much we screen or how much we do to look for prostate cancer, and that's one of the areas of our focus that we try to select men who really benefit from screening and might not benefit from going forward if they have other health conditions. But certainly men and typically prostate cancer affects men in the later years in their life, but can be in their 50s and 60s in some men. But on the other extreme, we have testicular cancer, which generally affects men in their late teens or up to age 40. So between 18 and 40, that's one of the most common cancers that a man might get is testicular cancer. And so again, caught very early, it's very curable, but without the awareness of this sort of screening or that sort of screening, men might put off their treatment for various reasons. And sometimes it's stigma, sometimes they just think it's going to go away. And that's where by involving other members of their family or just in general raising awareness to make sure that they know this is all very treatable is very beneficial for these men.
So let's pick up the conversation there. Testicular cancer certainly is less common than prostate cancer, but as you say, it's one of these that has some potential stigma attached to it, but could be treatable if found in the earliest stages. So help to educate us on what should people be looking for? What are those signs or symptoms that should really prompt somebody to go and get some advice on things before it gets too late?
Sure. So the most common sign or symptom that a young man or a gentleman would find is probably a change in his exam or a lump in the scrotum or on the testicle. And this can be small, it can be large, depending on when they first notice it. It may or may not be associated with pain, but most of the time this is picked up with just either routine exams or I'm doing normal hygiene and I felt something abnormal down there. Again, these are sometimes men in their late teens, early 20s, and sometimes they are a little bit squeamish about coming in and having it evaluated. But oftentimes it takes a little bit of prodding, and sometimes there's a little bit of delay where they put this off, thinking it's going to go away. But the earlier they come in, and be evaluated when they find something abnormal on their exam or just as they're doing their day-to-day activities, the easier it is for us to treat it, and it's very curable if it's caught early.
And so let's suppose, somebody is listening to this show and says, well, actually I did feel something. I really wasn't sure what it was. If they go to the doctor and they say, I found this lump, not really sure what it is, what can they expect would be the next steps? How is this worked up?
Sure. So typically when I see somebody, I would do an exam and evaluate the area as well. And then oftentimes we send them for an ultrasound. An ultrasound is a pretty quick test. It's an external exam test where there's nothing invasive, and basically allows us to view internally into the testicle and see if there's an area of concern or if this bump that they feel correlates to something concerning. And so that is one of the initial steps. It can also include getting some blood work drawn. And if there's concern, then sometimes a CAT scan as well. But the initial visit is usually an exam and then followed up with an ultrasound if there's something concerning.
And how often are these lumps actually concerning on ultrasound? Is it the majority of the cases that this will actually lead to something that warrants further investigation, or is it usual that these are simply nothing and people can just watch them?
Well, so there are a large percentage of abnormalities we find in the scrotum that are not concerning for testis cancer. There can be non-cancerous changes such as cysts in the epididymis or structures around the testicle that feel abnormal. And when somebody first finds them, they certainly are alarming and they should be evaluated. But a lot of those abnormalities we find are sort of incidental and can be followed that are non-cancerous. Very less frequently, we find that these are solid lesions within the testicle themselves that need to be evaluated for the potential for prostate cancer, testis cancer.
Yeah. So the idea being, of course, that if you find something, and I think that sometimes people often are either too scared to go to the doctor or they want to bury their head in the sand and think that this is going to be nothing. It's worth going to the doctor to have it checked out. It may well be nothing, but if it's something, it's better to find it sooner rather than later. Let's suppose you do the ultrasound and so on and so forth, and it is a solid mass. How is the diagnosis of testicular cancer actually made? Does this warrant a biopsy?
So usually it involves blood work and also eventually surgery. So we generally don't do a lot of traditional sort of biopsies of testicular lesions or masses if they look concerning on an ultrasound. And so typically if it looks solid on an ultrasound and it's well within the testicle, and also if there are blood work abnormalities for certain markers that we check for testicular cancer, then the diagnosis is fairly well confirmed off of just the imaging as well as the blood work. In rare circumstances, we'll do a biopsy in the operating room to assess that. For instance, if somebody has only one testicle or some sort of other sort of circumstances. But for the most part, if there is a significant level of concern, then typically the next step is surgery, which involves most likely removing the entire testicle.
And so I can imagine that when this condition affects young men, right, in their prime, 18 to 40 years old, the concept of losing a testicle might be, really kind of something that they may not be looking forward to, right? They may feel like that's part of their manhood, that they want two testicles, and how can they, function with only one. Can you speak to kind of some of the concerns that men might have when they're facing removal of a testicle?
Absolutely. This is, moving on from the delay in diagnosis, certainly the specter of going through surgery where I'm removing a testicle it's an adjustment for most men. And it takes, some degree of hand-holding through the process to tell them, well, this is an initial step. Your other testicle is normal, it's viable, it has enough testosterone production to make you male and still have normal sex drive and normal testicular function, as well as normal sperm production. So as far as, fertility in the future, that should all be preserved. There are some men that might need further treatment, such as there's a subset of patients that need chemotherapy after this procedure, where those men might opt for sperm banking ahead of time so that they have everything in their favor, that if they did want to have children in the future, they have viable sperm that are frozen somewhere, just in case the remaining testicle doesn't produce enough sperm afterwards. But from a functional standpoint, as long as the other testicle is normal, I reassure them that they can have a normal life with one testicle from a functional standpoint. And certainly cosmetically, we offer the possibility of putting on a prosthesis at the time of removal that gives the appearance that there are two testicles. I mean, obviously they feel somewhat different if you do an exam, but from sort of across the room, the scrotum looks preserved, that there are both testicles there. So those are options for men that are available to try to, alleviate any treatment-related concerns from a aesthetic standpoint or certainly a functionality standpoint.
And so you mentioned at the top of the show that if these are caught early, the prognosis is very good. Can you kind of walk us through, after a surgery, is there a difference in terms of the treatment for people who find their cancers early versus finding their cancers late? And what's the difference in prognosis?
Sure. So testis cancer is very well understood. It has a very predictable pathway of spread. Initially, it's in the testicle, and then eventually, if it goes untreated, it could spread to the lymph nodes in the sort of the back of the abdomen, we call the retroperitoneum. For patients who sort of have advanced testicular cancer where it spreads into those lymph nodes, simply taking the testicle off is the first step to get to the pathology and confirm the exact pathology, but also it drives further treatment. If those patients have advanced cancer where it is not treated initially, then they might need chemotherapy and then follow up with more surgery to remove those lymph nodes, which is a fairly reasonable size surgery. It's not as sort of an outpatient surgery like doing the testicular removal. So if those patients are caught earlier, they may or may not need that other surgery or certainly chemotherapy afterwards. So the delay in diagnosis can definitely impact survival for people who have, disease outside of the testicle and need these other treatments. Eventually their survival is in the high 90s, but there are further steps that need to be, further treatment steps with chemotherapy and more surgery. Potentially, if it was caught early, they would need those other steps, and the survival is still in the high 90%.
I think a lot of men also might worry about when they get testicular cancer, is this something that they then will pass on to their progeny, right? So is this genetic?
Very low likelihood that testicular cancer is genetic. There are very rare associations from a genetic standpoint. So I reassure these men that, they need to check their remaining testicle and make sure there's no other issues with that, about a 5% risk of having testicular cancer on the other side, but very low chance of passing this on to any of their male offspring.
Fantastic. Well, that's been fantastic information. We need to take a short break now for a medical minute, but please stay tuned to learn more about the care of urologic cancers with my guest, Dr. Michael Karellas.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Gastrointestinal Cancers is committed to detecting pancreatic cancer early and using state-of-the-art technology to treat the condition. Learn more at smilowcancerhospital.org. It's estimated that over 240,000 men in the U.S. will be diagnosed with prostate cancer this year, with over 3,000 new cases being identified here in Connecticut. 1 in 8 American men will develop prostate cancer in the course of his lifetime. Major advances in the detection and treatment of prostate cancer have dramatically decreased the number of men who die from the disease. Screening can be performed quickly and easily in a physician's office using 2 simple tests, a physical exam and a blood test. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, where doctors are also using the Artemis machine, which enables targeted biopsies to be performed. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Michael Karellas. We're talking about the care of urologic cancers in honor of Movember. Now, before the break, we spent a lot of time talking about testicular cancer, a cancer of the testis that often affects younger men, 18 to 40, and can have a really good prognosis if caught early. Now, the other cancer that I think many of us associate with urologic cancers is prostate cancer. So, Michael, maybe you can talk a little bit more about how prevalent prostate cancer is and the prognosis of that.
Great. So prostate cancer is very prevalent. It has an approximate diagnosis of one every 7 men over their life might get a diagnosis of prostate cancer. It's the second leading cause of death for cancer-related causes of death in the country, although about 3% of men only die from prostate cancer. So we're very good about diagnosing it early and treating it as appropriate, but it is very common.
And so, I think the one thing that has been a moving target and continues to be somewhat confusing for people in terms of prostate cancer is the whole aspect of screening. We know that for the majority of cancers, if you find it early, that's always a good thing. But in prostate cancer, I think people are still a little fuzzy as to, should I get a rectal exam every year? What about PSA? And even if my PSA is elevated, does that necessarily mean that I have cancer? Or sometimes I can just watch and wait. Can you talk a little bit about the whole screening issues?
Sure. Well, the conundrum of PSA screening and prostate cancer screening has been sort of ballied around the last few years. And in the urology community, we realize that we don't have the perfect test necessarily to find those cancers we need to treat and miss those cancers we don't need to treat. However, as imperfect as PSA is, which PSA is a marker that comes from prostate cells, it's our starting point. And the concern in the community as well, if my PSA is high, that means I have cancer. That's certainly not the case. There are a lot of PSA variations that are not cancer related, but also that causes the drawbacks. Well, then, if my PSA is high, why even check it? So we view PSA as a starting point, and there is utility in discussing the evaluation of PSA with men. And so we have a concept called shared decision making, that we recognize that PSA is not the perfect test. It doesn't mean you have cancer. And if we draw PSA, it might mean you might have to have further testing if it's at a concerning range. And that could be different for some men versus other men. But we know that if you have a baseline PSA in your 40s that's below 1, then your prognosis is pretty good, that over your lifespan, if you don't have significant risk factors, that's sort of good to have in the bank when you're young before we have other changes that could affect your PSA. So what we discuss with men is that, again, PSA is sort of a starting point, and it's worthwhile to discuss your risks for prostate cancer and whether or not you would benefit from screening. As a man ages, the likelihood they might die from other causes usually outweighs dying from prostate cancer. And so for men in their late 70s, early 80s, most likely the benefit from screening routinely for prostate cancer with the routine PSA or digital rectal exam probably is not quite as important as somebody who's 55 with a strong family history. So overall, we usually recommend a discussion of PSA screening, because without a PSA, there's no real way of otherwise finding a cancer that could have been caught early that might not be there. But again, the difficult part is PSA elevations are not in and of itself prostate cancer.
So if I heard you right, the recommendation would be to get a baseline PSA in your 40s. Is that right?
That's the general recommendation from the AUA and our national bodies. Now, if you have a first-degree relative with prostate cancer at a very early age, say your father had aggressive prostate cancer in his early to mid-50s, then we usually try to start about 10 years prior to his diagnosis. Again, to basically get a baseline of what your PSA is in order to follow the trend down the road. So if you're in your 50s or 60s, then PSAs can be annually if you have a really strong family history meaning first-degree relatives of prostate cancer, a mother with BRCA-positive breast cancer, or certain other risk factors, then it could be every year. Or if your PSA is relatively stable, then maybe a PSA every other year, every third year, depending, again, on sort of shared decision-making with your doctors.
Let's say you got your baseline test at 40 and now you're in your 50s or 60s and you're getting your PSA once every other year because you don't have a strong family history. Are there any other signs or symptoms that would make you concerned about prostate cancer? Or are most prostate cancers found basically by PSA?
One of the benefits of PSA is that the majority of prostate cancers we find now are very small and they're localized within the prostate. So very rarely do they cause any symptoms. And so most men now have, if they have prostate cancer, they're asymptomatic. There's no symptoms. And people often, say, well, I feel perfect. I have no symptoms, no problems. Men can have urinary symptoms as they get older from non-cancerous changes or growth of the prostate. And so that's something that we commonly see. That is usually not related to prostate cancer. Now, prostate enlargement can also cause the PSA to go higher because a bigger prostate would potentially make more PSA. But most men don't have symptoms from their prostate cancer per se.
So let's suppose you're going along, you feel fine, and your PSA is elevated. What happens then?
So usually at some point, either your primary care doctor or primary care provider or a urologist would do a rectal exam just to make sure they don't feel an abnormality in your prostate. And then usually the recommendation is further another blood test, and that could be another PSA, or there are more advanced blood tests available now that are more predictive of your risk for prostate cancer based on your blood work. So there are two tests that are proprietary that we often order as sort of a backup test. And if those are concerning, then the next step could be a prostate MRI if it's feasible. The purpose of the MRI is twofold. One is to evaluate the prostate if there are any areas of concern that might need to be biopsied. MRIs are very good tools, and we use them much more routinely than we did, say, a decade or 20 years ago. They're not diagnostic of cancer by themselves. They still have to be correlated with ultimately a biopsy if it's indicated. So I discuss with men that if there are concerns with your initial PSA, I usually recommend some backup testing. One is another blood test of some variety. If that's concerning, then we talk about getting an MRI, which again serves to see if there's a target there, and then ultimately a biopsy. The reason for the MRI before the biopsy is for twofold. One is to increase the accuracy of the biopsy, where you can target the spot that the MRI is finding concerning. And then from a staging standpoint, that ultimately if we do diagnose prostate cancer, having the MRI before we do the biopsy has it in an undisturbed manner so we can evaluate the margins of the prostate a little more directly to make sure that the cancer hasn't spread. So that's sort of a side benefit of doing the MRI ahead of time. So initial PSA elevation doesn't mean cancer. Likely means a little more testing, and then if the testing continues to be concerning, then ultimately likely a biopsy.
The biopsy part is the next part that I find we often get confused about, because you can have a biopsy and you can be diagnosed with prostate cancer, but it seems like not all prostate cancers are the same. There are some that have a low Gleason score where you may just watch this prostate cancer, whereas those that have a high Gleason score might be treated more aggressively. Can you talk a little bit about what exactly a Gleason score is?
So Gleason score is a pathology convention that the pathologist uses to grade the prostate cancer cells. So if when they look at the slide, if there's areas of cancer in the slide of the prostate cancer, if it's a very low-grade cancer, you get a lower score, meaning the cancer cells look more like normal prostate tissue and less like cancer, versus if you have an aggressive cancer, the cells are somewhat haphazard, and that gets a higher Gleason score, which correlates to a worse prognosis in theory. So the Gleason score is a sort of a system of numbers. You get two scores, which equal the sum, and the numerology sometimes can be a little bit complicated. But basically, if the lowest score you can get is a 6, which is the best score, and the highest score you can get is a 10, which correlates with the worst score, meaning the most aggressive type. And now we've sort of substratified to talk about Gleason grade grouping, which tries to eliminate some of the numerology if you have different sort of 3s and 4s and 4s and 5s and whatnot. We use the Gleason score or the Gleason grade grouping to assign men into a risk category, and that's based on national guidelines by various agencies. And so one agency is called the National Comprehensive Cancer Network, and basically they have cancer guidelines for all types of cancer, but for the prostate cancer guidelines, they are divided up between very low risk and very high risk and everything in between. And so we stratify men based on their Gleason score, their PSA, their physical exam. Using those components, we can put them into an algorithm, so to speak, where your cancer can be watched if it's a low risk or very low risk, and even some intermediate risk that are favorable, they can be watched. And then again, that is often determined by the combination on the Gleason score. If it's a unfavorable intermediate risk or above, so high risk or very high risk, those men benefit from treatment. So over the decades, we have a much clearer understanding of what types of prostate cancer are more aggressive and which cancers are not. And so 20 years ago, we used to treat everybody a little more homogeneously, that you needed to have your prostate cancer treated. And now we know that low-grade prostate cancer, say Gleason 6 or some Gleason 7s, very rarely kill men. And so there's a movement within some of our urologic oncology community to try to get those Gleason 6 cancers renamed to precancer to take away the stigma that this is something you have to treat. Part of our job is to discuss with men realistically, yes, this is cancer. This is the cancer that we can watch versus the cancer we have to treat. And sometimes that's a very hard discussion for a man to sort of conceptualize that this cancer won't kill you. But that's part of what we strive to do, to make sure that we stratify men, that this is something we can watch and spare some treatment-related side effects versus this is something we should treat.
Yeah, I mean, I think that one of the things that's difficult is to tell somebody this is cancer and all of the connotations that word has, and we're just going to watch and wait. And the patients may feel like waiting for what? Waiting for it to spread, waiting for it to get worse. But I think the point that you make is that these very rarely will progress. Is that right? And so can you talk a little bit about what exactly watchful waiting is and the frequency at which this will progress to anything substantial?
Sure. So for men who have low risk disease or very low risk disease, those men usually are very safe to be actively followed. So we call it active surveillance, and we do a PSA at 6-month intervals. And generally at a year from their diagnosis, we discuss the utility of maybe repeating the MRI and a biopsy. So the first biopsy is, we call it the confirmatory biopsy. It's sort of a second opinion biopsy to make sure that nothing was missed the first time, but also nothing new has developed. If that biopsy is stable, meaning no more aggressive disease was found than the first time, then subsequent biopsies are not necessarily every year, but we follow the PSA accordingly. So taking sort of the appropriate man with the appropriate follow-up, very rarely those cancers spread, and we have plenty of data to support that. And so it takes a little bit of sometimes buy-in from the patient, but we can offer them reassurance that this is the kind of cancer that's not going to ultimately kill them.
Dr. Michael Karellas is an assistant professor of urology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.